Hi, welcome back to my channel. What's up, Doodle Gang? Doodle Noodles. I don't know, I'm gonna come up with something fun as like what people that watch my videos are called, but for now it's just me that watches my videos because I use them to study. So, if any of my imaginary subscribers down below have any ideas, then, drop it in the chat. Okay, anyway. So today we're going to be talking about schizophrenia. And we're going to be also, I am sorry in advance if I yawn or sip water throughout this. It's just because for some reason I don't yawn, and the minute I start recording, I start yawning. So I don't know what that's about, but anyway, so what is schizophrenia? So schizophrenia starts out as a neurodevelopmental disorder that then becomes a neurodegenerative disorder. So, over time, if schizophrenia is left untreated, it does result in a reduction of lifespan and also decreasing quality of life for the person with increased positive, affective, negative, and cognitive symptoms. And we're going to talk about what all those are. So just a little overview. I'm going to be going over the symptoms and the causes of schizophrenia in this video. And then the next one's going to be about schizophrenia treatments because it's kind of a lot. So yeah, just bear with me on that. What is this line doing here? Okay, there we go. So, it's very schizophrenia, so you might be wondering, like, it's neurodevelopmental, but then I don't see, 6-year-olds with it. Well, it's common that it pops up between the ages of 16 to 24, and you might be thinking, well, why? It's because during this period, major synaptic pruning takes place, and if the correct neurons were not strengthened due to the lack of long-term potentiation and hypofunctional NMDA receptors, then loss of too many / improper neurons can result. And this will cause symptoms of schizophrenia. And we'll talk about how this happens, so don't feel worried if it's like, oh my God, it's a lot of words. But essentially, there's neurons, and for long-term potentiation to happen, an AMPA receptor, we'll just call this one AMPA, and a NMDA receptor, we'll call this NMDA. When glutamate comes in and binds to these two, it allows sodium to flow through here. And that sodium, this depolarization, allows for, there has to be magnesium here too. It allows for calcium to enter through the NMDA receptor. And this causes the pushing of AMPA receptors to the surface and secondary changes that occur in the cell and long-term potentiation, which is essentially just long-term changes to the cell that allow for stronger signals and increased strength in synapses over time. And if you don't have that, then if a synapse or if a neuron doesn't have long-term potentiation and strength in synapses, then it might be pruned and removed during this period. So if the synapses aren't functioning properly, then you can see how the lack of strengthening of these synapses causes more of them to be pruned, and them to be pruned wrong in the wrong neurons. So you're going to have all these other types of problems, and that's why it's neurodegenerative. But that also comes later without treatment. So let's talk about some of the symptoms and what you would look for. So first, the age of the person, typically between 16 to 24 years old, you're going to see this increase in symptoms. There's usually a period where someone will notice that a patient or the person starts to act a little different. Personality changes, flattening of emotion, and delusions and hallucinations are the biggest tip off, though, that something is has gone different. So there's 4 categories. So the first ones are positive symptoms. So those include delusions and hallucinations. Under this category, we also have catatonic behavior, agitation, violence, and aggression. So it's important to note, though, I put a little asterisk next to violence. People with schizophrenia are not necessarily more violent. We may not be able to predict their behavior as well because they're seeing things different than how we are seeing them. But that doesn't mean that they're necessarily more violent. And actually, it's more common that people with schizophrenia are the victims of violence. So just because someone has schizophrenia does not mean that they're violent or aggressive. But the delusions and hallucinations are a really key feature of schizophrenia that sets it apart. So hallucinations, this could be auditory or visual hallucinations, and then delusions are like false beliefs or kind of like thinking that everyone's watching you, or thinking that you are being followed, like excessive paranoia could be under this category. But a lot of these symptoms also kind of like blur together, because the next category is negative symptoms. And so we have blunting of emotions, alogia, which is speech and thought problems, anhedonia, so lack of pleasure, and then avolition, difficulty with motivation and goal behavior. We also have apathy here. So you can see apathy and blunting of emotions is like kind of similar. And then also when you get in here to like depression, well, depression can also have blunting of emotions, and you can also have apathy with depression. So it's like, it's kind of hard to like draw a line. But if they say like patient comes in with depressed mood, then you would say, okay, that's an affective symptom. So affective symptoms include like affect, which is what like your emotional state. So depression, anxiety, guilt, and tension. So these are just like, basically, I feel like they just put this for everything. And then cognitive symptoms. So cognitive symptoms is like slowing of thought, problems with speech, problems with executive function, doing things in the wrong order, not being able to do things properly, not being able to focus on what you're doing. So these are all symptoms of schizophrenia, but the key here is you will have these psychotic episodes with the delusions and the hallucinations. And then once it's controlled, you might not have these positive symptoms, because a lot of the medications are aimed at controlling those, but then you may have negative affective cognitive symptoms. So let's talk about how this happens. So in brain development, neurons are generated pre-birth in the developing fetus. And then some of these neurons are eliminated. You see this chart here. So there is some elimination of neurons. But then over time, these neurons jump onto the glial cells, and they are, this is still during development, by the way. They hop onto the glial cells, they catch a ride, and glutamate is released from the glial cells, and this allows for the maturation and differentiation of these neurons into what they're supposed to be, and also the development of synapses. So this is synaptogenesis. These neurons also in this process migrate to where they are going to end up. And then we have birth. And actually, to be completely honest, I'm not really sure about the order. I mean, I know this is the order, but I don't know like which part happens after birth. I would assume that these things happen first, but don't quote me on that, because I'm not a professional. I said this before, I'm not a doctor, not a professional, not a PhD, not a professor, just a person learning. But I will research this and come back to it. So anyway, I'm just going to remind myself here, say this is research. Back to this though. So the glutamate that's released from the glial cell strengthens the synapses and allows them to become stronger via long-term potentiation, because as we talked about up here, long-term potentiation requires glutamate to activate the AMPA and NMDA receptors. And then we have this chart here, and this is the key. So at between 6 and 16, you have this like kind of like steady state in the amount of synapses present. And then at age 16, this is like, puberty, whatever, we have this drop. So we have synaptic pruning. And this is why, learning is so important when you're younger too, because you kind of remain pretty steady state with the amount of synapses you have until death. So this change period here is why we see schizophrenia emerge in this time. Okay, so there's two major theories of schizophrenia, and there's the glutamate theory and the serotonin theory, and they tie in together, and it kind of explains like why schizophrenia has the symptoms it has. So essentially, up here we are in the prefrontal cortex, and this here is a glutamate neuron, glutamatergic pyramidal neuron, and it's synapsing with this GABA interneuron, and this GABA has an NMDA receptor on it. So let's just talk about the case that if this was not hypofunctional. So if it was normal. So if we had a normal NMDA here, Then glutamate would release here. It would bind. It would also bind to the AMPAs. I'll just put this as an AMPA. And this binding would cause, essentially would allow like calcium and the sodium to flow in, and then it would eventually signal, like could create an action potential, and then that would allow for GABA to be released from the axon terminal at the end over here onto this GABA alpha 2 receptor. So that's what could happen. Sorry, my hair clip is like bothering me. That's what could happen if everything goes like according to plan. But what happens in the case of schizophrenia? Oh, okay, wait, this is kind of important. So if GABA is binding here, then this is going to be inhibiting the release of glutamate onto the VTA. But in the case of schizophrenia, we'll get rid of these. Oh my gosh, I really did not think this one through. There we go. In the case of schizophrenia, we have this hypofunctional receptor. So that means that this is not going to allow for GABA to be released the same. So it's not going to, when glutamate comes in and tries to bind, it's not going to release, activate the same pathways and create as big of an action potential or whatever. So it's not as functional. So then you're going to have less GABA released or no GABA released. And then this is not going to inhibit. So you're going to have overexcitation of the glutamate neuron. And then this is going to cause high levels of glutamate in the ventral tegmental area, which is important in the tracks. And we're going to talk about these tracks down here. The pathways, the main pathways in schizophrenia. So honestly, I think what I'll talk about is the pathways first, then we'll come back to this because it kind of makes more sense like that. So we have this pathway here, and then, so we're coming into here and we have high glutamate. I'm just going to put high glutamate. Okay. Now let's talk about the major brain networks because this will help tie it all together. So first, we have the mesolimbic pathway, and this goes from the VTA, the ventral tegmental area, to the nucleus accumbens. And this pathway is responsible for pleasurable sensations, reward and motivation, and positive symptoms originate in this pathway. And we'll talk about the positive symptoms up in a little bit. So these positive symptoms, though, would include delusions and hallucinations. We talked about that, and seeing how that works comes in during the treatment phase. The mesocortical pathway is involved in cognition and executive functioning, and this includes the dorsolateral prefrontal cortex and the ventromedial prefrontal cortex. When there's low dopamine in the dorsolateral prefrontal cortex, this results in cognitive and negative symptoms of schizophrenia, and the ventromedial prefrontal cortex results in negative and affective symptoms in schizophrenia. It's important to note that there's no DATs present in the prefrontal cortex, and most of the dopamine receptors here are D1. So this means that they're excitatory. And this is important because this explains some of the symptoms of schizophrenia. So let's just go back up. So we'll do these two. So first we have this pathway here. So here to here to here. We start here 1, 2, 3. This is the mesolimbic pathway. So we have high glutamate, and then this is going to cause high dopamine here. And then high dopamine is going to cause high GABA activation. High dopamine is going to cause an inhibition of GABA because these receptors here are D2. And so that means that they're inhibitory. So we are going to have low GABA. So this is going to cause an increase in the ventral palladium, the increase in stimulation, and this ventral palladium is really important for desire and wanting. And when there's high levels of dopamine, so that means that there's low levels of GABA, there's a high desire and high wanting. But when there's high levels of dopamine antagonism, GABA is now no longer inhibited because dopamine is not signaling to GABA. So there's going to be high levels of GABA, and this is going to inhibit desire and wanting and cause could cause something like flattening of emotion and like apathy. And this is commonly like a secondary negative symptom that occurs with treatment of schizophrenia with D2 antagonists. And then we can also see over here in the mesocortical pathway, high levels of glutamate will activate GABA, so this will lead to high GABA. And then high GABA is going to inhibit dopamine, so this is going to lead to low dopamine. And this is the mesocortical. And low levels of dopamine in this pathway are going to result in negative and cognitive symptoms for the DLPFC and negative and affective symptoms for the VMPFC. So that's why we have this. And the mesolimbic pathway over here, when there's high levels of dopamine going through this is going to result in hallucinations and delusions. Okay, and then this is just this picture. The mesolimbic pathway is just showing that on the mesolimbic pathway in the VTA, which is the presynaptic portion, there are dopamine reuptake pumps present, and there's also on the postsynaptic GABA neuron, it's mostly D3 and D2 receptors, which are inhibitory. So when dopamine binds here, this will result in the inhibition of GABA. And so the overactivation of this area of the brain will result, and this causes the positive symptoms. Okay, so scrolling on down, we also have the nigrostriatal pathway, which involves the substantia nigra and the ventral, which goes to the ventral striatum. And this pathway functions normally in some people with schizophrenia and also abnormally in others. But for the most part, they just say that it, in like the textbook, it just says that the substantia nigra to ventral striatum pathway functions normally, so their movement is not affected, them being patients that have schizophrenia. And it's important to note that dopamine allows for movement regulation. And so when you give a treatment for the positive symptoms of schizophrenia, such as a D2 antagonist, this will result in changes to the amount of dopamine present in the nigrostriatal pathway, because you can't like target specifically one part of the brain, as we've talked about in other videos. Like you can't spot treat sections of the brain if they have the same receptors. If it's a unique receptor to that specific portion, then that by all means you may be able to. But in this case, if it's a specific receptor, then you're going to be affecting all of the places in the brain with that receptor, like hypothetically. So, yeah, but the nigrostriatal pathway we'll go over when we go over treatments. So look out for the next video after this. We'll go over that pathway more and how it's affected by the medications given. And then finally, we have the tuberoinfundibular pathway, which goes from the hypothalamus to the pituitary. And this is important in schizophrenia because it regulates the controls the regulation of prolactin. And prolactin is what stimulates milk production in women, and actually can stimulate milk production in men too, because men also have prolactin. And when I say women and men, I just mean the person was assigned the sex female or they were assigned the sex male at birth, and then they have the parts that are like scientifically or like commonly associated with those two genders. But even people of all sexes, genders can produce prolactin. And so if a biological male is given a treatment for schizophrenia, such as a D2 antagonist, their levels of prolactin will rise, and then he may be able to produce milk. And this is because dopamine normally inhibits prolactin. So when dopamine binds, it inhibits prolactin. But if you give a D2 antagonist, this prevents dopamine from binding, so it blocks the action of dopamine. So this removes the inhibition. So this increases stimulation of prolactin because you remove the inhibitor. And so this will come into play when we talk about a medication called cariprazine, which, and also the second gen antipsychotics, the atypical ones, because they have a 5-HT2A receptor, or a 5-HT2A antagonist, which blocks the normally stimulatory action of, if serotonin was to bind here, this would stimulate prolactin release because the lactotropes produce prolactin. But if you have an antagonist that blocks the serotonin molecule, this would actually result in inhibition. And so there would not be stimulation. So then you get this kind of like balancing act, and this allows for normal prolactin levels. Okay, and then just to summarize the end of this video, sorry, this video kind of fell all over the place. Schizophrenia is just a really big topic, and it's hard not to talk about the pathways without talking about the treatments, because I'm going to talk about it again. So we're just going to go back to that in a moment in the next video. But I'm just going to quickly highlight the pathways again. So we all go from the glutamate to the GABA to this second glutamate right here. So this pathway from the VTA to the nucleus accumbens is the mesolimbic pathway. And this is the one that's involved in reward. From the VTA to the dorsolateral prefrontal cortex and the ventromedial prefrontal cortex is the mesocortical. This visual cortex is involved in the hallucinations and has parts of the raphe nucleus that project to it. And so serotonin, high serotonin levels can help increase hallucinations. Oh my gosh. And then coming back to the major theories, this is why the serotonin theory states that if you have high levels of serotonin on the 5-HT2A receptors will bind and stimulate the glutamatergic neuron to fire, and then increase downstream effects of this neuron. So if you have a combination of low GABA plus the normal stimulation of serotonin, this is going to cause overactivation of glutamate. And this is going to cause downstream positive symptoms, negative symptoms, affective symptoms, cognitive symptoms, all the symptoms of schizophrenia. So that's how the serotonin ties into this. And so that's why we can use drugs that have a serotonin component, but also a dopamine component to treat schizophrenia and its associated symptoms. Okay, so I hope that helped. And you were able to better understand the different pathways in schizophrenia, the two major theories, the glutamate theory and the serotonin theory, and the symptoms of schizophrenia. I'll see you in the next video.